Hi, everyone. I'm going to give it about a minute and just make sure everyone can get in the room. All right, it looks like we've got everyone's. All right, well, so thank you so much for joining us today for our webinar Wednesday. Today's topic is advancing public health through trauma-informed approach, and is presented by Dr. Anthony Dissen. So just a couple housekeeping notes before I turn it over to Dr. Dissen. If you have any questions, please put those in the Q&A area and the presenter will answer those at the end. And if you want, we do have chat open so you can interact with your fellow attendees. Feel free to put comments in there, where you're from. We love to hear from you and make our presentations as interactive as possible. So with that, I'm going to turn it over to Anthony for today's session.
Marvelous. Thank you so much. Thank you, everybody, for taking some time out of your day to be here. And as always, thank you to the National Board of Public Health Examiners for making this possible and for giving us the opportunity to share this information. Yes, I'm very excited to spend a little time with you all today about this very important topic that is getting more attention in the field, which is exciting, but still needs, I think, a little more broad understanding or broad discussion. And I'm hoping everybody here will be able to continue this discussion in your own areas of work after today on a trauma-informed approach to public health work and public health practice. So just very briefly, a little bit about myself. I am a faculty member at Stockton University. I am a tenured assistant professor of health sciences. I teach in our Bachelor's of Science in Health Science program, as well as our Master's in Public Health program. And my scholarly work and my research in public health is mainly focused on LGBTQ plus health, specifically how LGBT people, queer people, and non-binary people and communities interact with the healthcare system, specifically in areas related to the competence and the readiness of healthcare professionals and practitioners to work with this community, but as well as bringing greater awareness to unique health needs and, of course, health disparities within the queer population. My background is also in nutrition and dietetics. I'm a registered dietitian. So a lot of my work also focuses on specific food and nutrition needs, considerations, and again, disparities in this population. An area that I spend a lot of time talking about and also enjoy is medical and healthcare misinformation. So there's never a dull moment there. And how communities evaluate and make judgments about the health information that they come across, particularly on online and social media platforms, and how they make those decisions about what they deem to be safe and true or what they deem to be misinformation, and just how accurate they are at doing that. But for today's purposes, we're going to be talking about trauma-informed forms of public health practice. And so what I want to do today for our webinar is just to go over a little bit about what trauma-informed practice and care are. I know for some of you, this may be a topic you're already well versed in. For others, maybe not so much. So I just want to go over some key details here. What is the connection between trauma and experiencing trauma, particularly in childhood, and current and future health disparities and social determinants of health? And then what does it mean to engage in what is called trauma-informed practice and trauma-informed care? What does that mean in a practical and applied sense? What are those principles of bringing this into actual professional practice? And then what are some of those next steps that, again, hopefully we can all bring back to our areas of work and practice to bring a more trauma-informed lens into our areas of work? So trauma is, of course, a topic. It is a word that we hear used quite a bit. And it's exciting just how much this is beginning to gain greater and greater attention. But sometimes with these words that gain a lot of societal use, we don't always have a common or a universally understood definition. So while there is no one, of course, definition of trauma, a well accepted aspect of at least of that definition is that trauma is a result of either an event or a series of events. So this can be from an acute exposure to something traumatic or the accumulation of traumatic exposure over time, or the lived circumstances that a person or a group of people experience that lead to physical and or emotional harm. And this can be very, I don't want to say invisible for lack of a better word. This can be easily missed even by the person experiencing trauma, or it can be in the most direct, overt, life-threatening kind of way. But the key thing here with trauma is that it has long-lasting effects. Trauma is not necessarily the event itself. Trauma is the response, the physical, mental, and emotional response to a single or a group of events that lead to some kind of negative outcome or experience. So then trauma-informed practice, or sometimes as it's used, trauma-informed care, is the approach that is being encouraged to be taken within the healthcare field, social services, and public health that gains a greater recognition and discussion around the widespread impact of trauma. So, the goal of trauma informed practice and trauma informed care is to basically do what we are doing right now. It is to gain greater awareness of how universal and, frankly, how incredibly common this is. Because the goal, as anytime we are trying to expand our knowledge and awareness of a topic, is to change how our skills, our services, our work is delivered to communities and populations. So, the goal of trauma informed practice in public health is to enter into our work with people, with communities, with populations, coming from that lens, coming from that mindset of what happened. So rather than saying what's wrong with you, which is maybe not always done in a cruel way, it's just a very common health kind of default, I would say, in our country, right? Of just, well, what happened? What's wrong? What's the issue? Trauma informed practice asks us to not look at it as such a what's wrong with you, as if you, the person, or you, the community of people, has something inherently wrong. It's what happened? What is that narrative? What is that story? What is the history to you as a person or to you as a community of people that may be impacting your health now and continuing to impact health into the future? Trauma informed practice is not a specific protocol, it's not a specific therapy. So, as we'll see today, it's not that there is a highly regimented way of practice. It is a framework. It's a philosophical approach to how we work, speak with, engage with, educate, gather data from people who may have experienced some kind of trauma recently or even in the distant past. The reason why public health benefits from a more trauma informed lens, if you will, is because trauma is both a consequence of the social determinants of health that we find ourselves in, but trauma is also a driver of these social determinants of health and the health disparities that result from them. So when we think of societal influences and the kind of societal triggers for trauma, if you will, we have things like discrimination. We have things like racism, immigration-focused trauma, which of course is nothing new, but is especially heightened in our world and our community right now. Political factors. These things are not unique to any one moment of time, and of course they ebb and flow with time. But these kinds of societal influences, especially on people who belong to communities, identities that may be particularly targeted or at least regularly spoken about in the news or in societal conversations about health, about crime, about disease, about violence, whatever this kind of societal narrative might be, this creates kind of an ongoing psychic shell in which people find themselves in an ever-growing low-grade sense of fear, of worry, of concern, of trauma, of uncertainty about how to navigate the world around them. Economic stability. So, people or communities that regularly face fears of eviction or higher rates of eviction, loss of job, loss of employment, just security in general, people working job to job or people balancing multiple jobs. People that, of course, live in lower socioeconomic environments and status tend to have higher exposure to violence, especially as children. And these can lead to the kind of ongoing traumatic impacts that even if they find themselves removed in the future, I get my education and I get my job and I'm in a better space than I was when I was a child or a younger person, the effects of that trauma can still absolutely be there. Um, Things like poverty, food insecurity, home insecurity, exposure to community violence expose people to other types of traumatic events, loud noises, the inability to sleep well at night, poor options when it comes to food choices. So, people living in food deserts or people experiencing food apartheid. A kind of a low grade PTSD, if you will, can result from even events that happened years in the past. Of course, education access is going to be a major issue. So, not only do people who find themselves in lower socioeconomic status environments have a harder time accessing and maintaining quality education, those educational opportunities may be less or not even existent for them at the same time. When people, especially children, experience trauma, they tend to struggle academically, have higher rates of dropout, and lower rates, of course, of expending their education then into higher education. Home environment. Family stability, family forms of trauma, of course, are going to be very impactful for everybody involved. Yes, for the children, but even for adults in that kind of environment. Home environments that are subjected to discriminatory or racist or other types of violent attacks. People that are in environments where they feel that their home is targeted in some way. People that may also be experiencing poor health messages. All of this can be just a general ongoing cue in the environment they find themselves living in. And then, of course, healthcare access. Not only the lack of access to healthcare itself, but people who experience ongoing trauma tend to have greater fears and distrust of the healthcare system, both clinical and public health. Because especially if somebody has grown up in an environment or a community where they've seen social services break up families, where they have seen law enforcement target different people, where they have seen healthcare providers not give dignity and time and attention to the people that come to them from care, this leads to distrust, a fear of re traumatization, and provider bias. So, therefore, often we will see people in these traumatized environments then not go on for ongoing health care, not go to health fairs, not go to their clinician for an annual physical or mammogram. And so we see these higher rates of health disparity build because they're not getting ongoing access to care because they delay the ability to access care because of that fear of not wanting to find themselves again in a traumatizing situation. More and more research is being done on just how much this isn't only a psychological response, there is a very real physiologic response. We know that people who experience chronic trauma have an ongoing activation of their sympathetic nervous system and that stress response system. And this has been associated with hormonal dysregulation. This has been associated with ongoing higher rates of inflammation. This is being looked at into a potential causative risk factor. So, not just the idea that ongoing trauma leads me to engage in unhealthy behaviors, and this increases my risk of things like diabetes, heart disease, depression, anxiety, weight dysregulation, cancers, but that the trauma itself and the way that the body reacts to that trauma is itself a driver for higher rates of these chronic illnesses. But at the same time, again, these behaviors are impacted. People who have experienced ongoing trauma, chronic trauma, tend to have coping mechanisms that are not the most health supportive, such as abuse of alcohol, the use of tobacco products, food and overeating as a coping mechanism, substance misuse, etc., for unaddressed and unresolved stress and trauma. And so we see kind of both sides of the coin in this way of we put out these messages about what healthy living, healthy exercise, stress management, seeing my physician for an annual physical, all of these good messages, but they may not be able to be accepted by people who are chronically exposed to trauma. And so the idea here isn't that public health professionals don't care about people with trauma. It's just that if I am designing education campaigns, outreach campaigns, social marketing campaigns, if I'm trying to get people to get screenings for skin cancer and ovarian cancer and all these other different kinds of things, If I'm not coming from it from a trauma-informed approach, I may just not think about, well, people may not want to come here because they don't trust us. People may not want to come here because they're afraid of being targeted in some way or judged in some way. So that is why this trauma-informed approach to practice is more of a philosophy and a framework versus a completely different way of practicing. These health disparities, of course, are then further compounded in marginalized communities, in communities that have already been experiencing things such as ongoing racism, historical poverty, ongoing effects of colonialism, sexism, homophobia, transphobia. People who are already impacted by structural inequities experience trauma with greater frequency, often greater intensity, and with fewer protective factors. And so, again, we see this ongoing disparity of people who already move through the world with a bit more privilege, with a bit more protection, are not only less likely to experience trauma, but if they do experience trauma, tend to have more factors, more resources in their environment to help them cope with and heal from that trauma than those who are more marginalized in terms of their historic, disparities that are being placed upon them. These ongoing worsening experiences lead to lower life expectancy, worse health comes, and again, further distrust of the healthcare system. And so, this is where we as health professionals and public health professionals just want to acknowledge this and think about this more as we speak with people and design the ways in which we go out into the world. When we talk about trauma-informed practice, a common point that will come up, and that again, maybe some of you have come across this before that may be familiar, are what are called ACEs, adverse childhood experiences. This isn't anything new. This is something that for the last quarter century or so has been known and discussed. But a lot of this came out of a study at the end of the 20th century by the CDC and Kaiser Permanente, where they kind of helped to coin the phrase adverse childhood experiences or ACEs, and finding that those who had experienced these had significantly highly worse health outcomes later on in life. And so what they did was they described 10 different categories of different types of adverse childhood experiences that can collectively be put into three different domains that children might experience before the age of 18. The first is, of course, abuse, which can be sexual abuse, physical abuse, or emotional abuse. Different forms of neglect, both physical neglect and emotional neglect. And then the other category or domain is household challenges. Growing up in a household with one or more parent or guardian or family member who are incarcerated. People within the household that experience some kind of mental illness. People in the household that are experiencing substance dependence or substance misuse. Uh, Children who grow up in houses where parents or guardians separate or divorce, or of course, children that grow up in environments where parents or guardians are having violence. One or more partner is exhibiting violence against the other. These were found to be the most toxic, if you will, forms of adverse childhood experience that might have more long lasting effects into adulthood. And so these ACEs, if they are not buffered by protective factors, so even if a child grows up in an environment where these factors are present, if they have a highly attentive parent or adult or guardian or a school system or somebody that can swoop in as needed and provide support, provide attention, provide affirmation, etc., that helps to negate some of the negative impacts of these events. But for children that are in environments that do not have these buffering factors, these protective factors, this led to a type of stress that was deemed toxic stress. And it is this kind of toxic stress that was found to have long lasting, damaging impacts on the physical and mental health of the child that were detectable as early as infancy. So, of course, anybody into their childhood that experiences these are going to be negatively impacted, but often there can be a misconception or an idea that, oh, well, if the child experiences these traumas, early on in life, infancy, before they're really going to establish these as permanent memories, it's okay. Okay, we got them out of that environment, everything's fine. Even those children at infant ages that experience these adverse childhood experiences were found to suffer the impact of this toxic stress later on in life. And so from UCSF, in their Center to Advance Trauma-Informed Healthcare. What was found is that for people during the ages of from birth to 18, if they experienced 4 or more adverse childhood experiences, they were, as we could see, about 40% more likely to have diabetes later on in life, 2.3 times more likely to develop cancer, experience heart disease or a stroke, 3 times more likely to use tobacco products, a little over 3 times more likely to have a chronic lower respiratory infection or some form of lower respiratory disease, 5 times more likely to have major depression as an adult, 10 times more likely to experience drug abuse or some kind of drug misuse or dependency. And what shocked me the most when I first came across this information, 37 and a half times more likely to attempt suicide at some point in their life. And so this cannot just be explained away by, well, there's something bad happened in childhood, but now they're okay. They're adults. They got an education. They got a job. This is where that trauma-informed approach comes in to say that it isn't just bad things happened then, but they're out of it now. Even if someone has found themselves in a healthier environment or set of circumstances now, to have experienced just to go back really quick, to experienced 4 or more of these types of adverse experiences, the effects into adulthood are significant and measurable, and have powerful impact on not just their personal health, but of course in the health of their community. So when we attempt to engage in what is called trauma-informed practice or trauma-informed care, what we want to look at this as is systemic and a more holistic or macroscopic approach. Because yes, we look at the individual, of course, but it goes back further than just an individual or even a community. It actually goes back further in time. And so the areas that are most easy to identify, the areas that are most visible, kind of tend to be here at the top of the pyramid. Okay, I can know whether somebody's had an adverse childhood experience. We know that that can lead to that disruption in their neurodevelopment. So why is it that they're 37 and a half times more likely to experience an attempt at suicide? Having 4 or more of those adverse childhood experiences changes the way their brains develop. It has significant measurable neurodevelopmental harm. This, of course, leads to social, emotional, and cognitive forms of impairment, which can lead to the adoption of more high-risk health behaviors. This, of course, increases the risk for social problems, disease, disability, injury, and, of course, early death. But what we want to look even further back here is the foundation of this pyramid, the local and the social conditions and context in which a person finds themselves. Very rarely um, are these adverse childhood experiences a fluke. And what I mean by that is it just happens to be that a child is in a home environment where things are harmful. Yes, that home environment is harmful, but why? What are the social conditions? What are the local histories or contexts that facilitate the development of a harmful or a toxic home environment? Well, that can be explained by generational and historical forms of trauma. And this is why narrative and story and history and giving people the opportunity to not only tell their story, but we as public health and health professionals need to learn and understand those stories, because it is rarely a fluke. It is rarely this was just a harmful parent, or this was just a harmful environment for someone to have found themselves in. That harm has a history. That harm has an origin. That harm has roots to explore. These things don't just happen, for lack of a more academic way of saying it, right? There is generational and historical trauma that leads to the kind of educational, economic, social disparities that breed the kinds of environments that put a child or anybody at risk for developing these adverse childhood experiences. And in the ongoing cyclical nature of this, people then who develop these social, emotional, and cognitive forms of impairments and adopt these more risky health behaviors further continue the generational trauma into the next generation, into the next generation. And so we see how this feeds in a very vicious and kind of deadly cycle, the continuation of groups of people finding themselves in the environment that create and sustain trauma. So when we look at this from a healthcare perspective, and often in healthcare, we look at these things more microscopically, individual trauma. This just affects one person. But that is the exception. Typically, individual trauma experiences or comes about because of familial or group trauma. So, multiple members within a family are all going to be experiencing the same issue, not even just the child, but the parents. If a child is raised in an environment that is economically disadvantaged, well, the parents are economically disadvantaged. But often people find themselves in the environments because they belong to groups that themselves experience trauma over and over. So, for example, people within LGBTQ population, people of different socioeconomic backgrounds, different demographic backgrounds, racial backgrounds, and ethnic backgrounds continue to experience trauma, typically at the societal level and others, that reinforce these harmful events over and over. But these groups can also be in areas such as vocation. So, for example, people that are first responders, they experience traumatic events over and over. And then often without meaning to, those traumatic events as they impact their health then comes home with them. So if they live with family, if they live with friends, if they have children or have a spouse, anything they're doing in terms of tobacco usage, alcohol usage, behavior issues, emotional dysregulation, again, this bleeds out into other people that they come into contact with. From a wider, though, perspective, we can see and need to see more of the community trauma. So, what are those cultural, racial, historical forms of trauma that continue to breed areas in which people cannot escape or have a difficult time escaping the kinds of events that can lead to re traumatization or new traumatization? So, this is where I believe we as public health professionals can really come in a very powerful and cohesive way, is to take our approach, which is to look at communities, to look at populations, to look at groups of people, and say before we hyper focus on the individual, which is not to say that an individual's health needs and an individual's traumas are not important, but where did that stem from tends to be from this more communal level. So at that community level, we look at this idea of mass trauma. So people within the same identity group, people within the same community, people with the same history. What are the ways in which these stories continue to play out that cause people, regardless of what their other circumstances in life to be at a higher opportunity to experience these traumatizing events? So this is where cultural competence and cultural humility comes in as an important way to begin to shift and think about the ways in which we practice from a more trauma-informed approach. So just as there is no one definition of trauma, there is certainly no one definition of what culture means. But culture can mean a number of different aspects of a person's identity. So social norms and behavioral norms. How do people act? How are people expected to act? How are people expected to interact with each other and behave with one another? This can be a very important area when we are attempting to understand those roots, those histories. Because if it is my goal to, let's say, work with indigenous Native American communities within the United States and talk about disparities that are being experienced within people within this community through trauma, well, the first thing I need to know is, well, if I don't belong to that particular cultural group, that particular identity group, what is considered healthy? What is considered, normal? What is considered socially acceptable versus unacceptable? Both so that I may myself act appropriately and respectfully when interacting with people within this community, but if I come in with my idea of what I think normal or abnormal is, with healthy or unhealthy is, I am not going to understand the full breadth of what is actually happening within this community if I don't possess that knowledge. So, what is the history, the value system, the shared experiences, really building that knowledge of a particular group we may be working with? And what are those traits, those norms, those daily habits, those customs? Part of trauma informed practice is the building of trust. And we'll talk about that more in just a moment. I cannot build trust with people, especially if I am not part of that particular group. But even if I am part of that group, just because I myself am part of a particular racial group, ethnic group, religious group, sexual identity group, doesn't mean I just magically possess all the knowledge that there is to know and all the ways in which norms and customs present themselves over time. I need to make sure I'm keeping myself up to date, that I'm gaining the knowledge and the information needed so that when I speak to people, I know what to say. I know how to act. I know what is considered respectful or disrespectful, and I know how to properly assess what it is that I'm seeing. What are those styles of communication, idioms and language, coded types of communication? This is what it is to build culture and cultural competence so that before I can work with a group, even if this is children, well, what are the social and behavioral norms of children? Children aren't just tiny adults, right? They have their own knowledge system, they have their own value system, characteristics and customs, styles of communication. And just because I used to be a child way back when doesn't mean that the way I behaved as a child is the way that children behave and act now. So anytime we're going out into a community, into a population, before we do, we want to really take that moment of self reflection and say, what do I need to know? And what do I think I know? And why do I think I know that? So that I'm able to act appropriately. To do so usually requires us to engage in what is called cultural humility, which is that ongoing process of self reflection, self awareness. Why do I think this? What is my worldview? What are my beliefs and attitudes and biases? Can I remain open to new information, new points of view? Maybe I agree or disagree, or maybe agree or disagree isn't even applicable, but am I open to new information? Very often we in the royal sense can get stuck in it. Well, this is just how it's done, or this was true then, so it must be true now. Cultural humility asks us to say just because something was true even 10 minutes ago doesn't mean it's still true today. So, what I might believe to be the way in which, let's say, people who are part of the disabled community might behave, share, and practice because that's what I was taught in grad school, or that's what I learned back, that may have shifted. Technology shifts, cultural and norm and social mores shift, language and terminology and slang shifts. So I want to keep checking in and say, if I want to keep advocating for members of the disabled community, especially from a trauma informed perspective, how do I keep myself open? Am I listening to the newest interviews, stories, narratives that are being shown? Am I keeping up to date with what's being shown in media and entertainment? I mean, this is what it is to keep ourselves abreast of what it is we need to know so we understand the current lived experience of the communities that we hope to work with. So when it comes to trauma-informed practice, again, from a more philosophical or framework stance, these are the major 6 principles of what it is to do. So first and foremost, safety. Even if I can only do one of these things, to create an environment where people feel safe, to create an environment where we default to how can we aid in a sense of safety. And when we create an environment where people know that their safety and their confidentiality matters to us, people will not seek out the work, the skills, the services of the healthcare field if they do not feel safe disclosing, showing up, talking about themselves, sharing their pronouns, talking about their drug use or their sex habits. People need to feel trust and safety in order to share that kind of important information. Trustworthiness and transparency is key. And I think, frankly, public health, for the most part, does a very good job at this, but we can always do a bit better to really be transparent and to build a greater sense of trust. Where people often have fractures in that sense of trust is when they feel that public health organizations, agencies, researchers kind of swoop in, gather data for a study they're doing, and then leave, and the community or the population is left feeling used. Like, well, they just came in to get their next research paper published and now they're off. So, what do we do to actually create an ongoing presence to let people know we're here? You can trust us. Here's why we're here. What can we do? What do you want to ask us? We're not keeping anything off the books here. No, everything is out in the open. People have to trust. Traumatized people need to know that they can trust to share these intimate details and these histories about themselves and to know they'll be treated with respect. Empowerment. So oftentimes when language around stress and trauma come up, it can be patronizing, and not purposefully, but it can be in that sense of, I'm so sorry this happened to you. This is so awful. This is so bad. That must have been so terrible. And it's not that those aren't sentiments that are shared with kindness, but people don't want to be pitied and people don't want to be infantilized. People want to be helped and supported and empowered. So, trauma informed practice asks us to acknowledge trauma, to not be dismissive of it, but how do we craft our work to say, this happened? Here is how you are, what can be done. You survived that trauma. Yes, it might still be impacting you, but you are alive and functioning right now. That is a testament to your strength. That is a testament to your resilience and your grit. So empowerment is very important so that people don't feel that they are being pitied or judged or felt sorry for or seen as somehow broken or less than. The other important area that comes out of trauma informed practice that, again, public health is just naturally well tuned for is collaboration. We are an interprofessional, interdisciplinary field, and this aids our ability to collaborate. So, yes, health, but also education, transportation, housing, local legislation and efforts. What can be done to create a coalition of people that can collaborate and work together in this interprofessional way to address the needs of a community. And that this is seen as a sense of mutuality. This collaboration needs to involve, of course, the community members. So, community based research, community based participatory research, where stakeholders within the community itself come in are brought in, which further enforces trustworthiness, safety, empowerment, all these other factors by saying you're part of this. We're not going to come in and fix you. We're coming in to work with you to bring money, resources, data, anything we can to create a healthier community. And as we were speaking about before, cultural competence, cultural humility, understanding the cultural, historical, and other identity based issues that are at play to make sure that those are not being ignored or passed over or muted because they're seen as too controversial or too complicated or too messy. That these are part of people's identity and they again need to be seen as strengths as opposed to things to get out of the way so we can get to the real work, if you will. And then lastly, peer support, both peers for us, we ourselves need to work with our own peers for support, for help, for guidance, but to also get people within the community to support each other too. One area in which this has been shown to be profoundly helpful is in the field of oncology. So it is known, of course, that to receive a cancer diagnosis is not just traumatic to the patient, but to their family, their community, their caregivers, anybody in that immediate circle. It is traumatizing to have a loved one suddenly diagnosed with a very serious illness. And one area that comes out continuously in cancer survivorship is that those who engage in peer support opportunities, so attending support groups, working with mental health professionals, social workers, etc., survive. But not only that, thrive better than those who do not. And their family members also need that support. Caregivers need support. People within the community need to come together and say, it is difficult to be the spouse, to be the parent, to be the sibling of somebody undergoing cancer treatment. So, for example, if anybody's familiar with Gilda's Club or cancer support communities, they have really done an amazing job of saying it doesn't matter if it's your next door neighbor. That is still traumatizing to you as a person that someone you know and care for has been diagnosed with this illness. So you too can come for peer support groups and other types of programming to get you here to let your emotions out and to give you the support you need. And it has been shown in a very measurable way to help everybody involved, both the person going through treatment as well as everybody else who knows that person. And then, of course, in areas of bereavement as well. So these principles of trauma informed practice, as we could see, they're not necessarily groundbreaking. It's nothing that probably most of us aren't familiar with to some degree. But the goal here is that it helps us to acknowledge. We put the recognition that these life events last decades into the future and they shape our health behaviors and our health outcomes. And it's not to do this in a way that says you cannot escape from your past or you cannot escape from your trauma. It is to say, we recognize that your past, these traumatic events were real and they have lasting effects. They are not your fault. These have upstream causes: poverty, violence, racism, discrimination. These are factors that have nothing to do with you as a person. It's you experienced this trauma not because you were not strong enough, not because you were dealt bad cards in life. There are social, societal factors at play that lead to the very real presence of these traumas. And therefore, we are going to design systems that are inclusive and that are knowledgeable and conscious of these to avoid re traumatization and actively working to build better trust within communities. We continue to be overrun, right? I mean, let's all be honest about this, just the shape of our current society. There is distrust. If there's not one other, if there's nothing else we can agree on, we can say there is a tremendous sense of distrust. That trust has to be re-earned and rebuilt, and we have to see what is eroding trust in our healthcare forces and our healthcare efforts. This is active, purposeful work, because if this trust is not regained, if it is not earned, then our systems not only can't be inclusive, they can't be helpful to the people who most need them. And then lastly, we need to, of course, make our care accessible. And we make our care more accessible by making it present, by making it safer, by making it culturally informed and responsive, and by making it empowering. We need to create permanent, ongoing areas that people know they can safely go to and they will be respected. So, as an example of a case study, because these things can always, I think, work better when we actually think of them in a specific way. So, for example, if we had just an individual 35-year-old woman, Maria, referred to see a community nutrition program at a local public health clinic because she has type 2 diabetes. She's struggling with her blood sugar levels. She's had bad and negative experiences with healthcare professionals, nutrition professionals in the past who dismissed her concerns about food access and her cultural food preferences. So she goes to this public health clinic. She's withdrawn. She's anxious. The community nutritionist asks her about her dietary habits, and her answers are short. She avoids eye contact. She eats a lot of fast food. Cooking at home feels overwhelming. She hesitates before revealing that she has been a survivor of domestic violence, and she's living in a temporary shelter with 2 children, and is therefore experiencing food insecurity and has lack of access to fresh produce. Now, anybody working with Maria here, of course, would want to provide her with help. And it's not to say that somebody without a trauma-informed approach to practice couldn't be beneficial to Maria. But what a trauma-informed practice, what a trauma-informed lens of care does, is it allows us to, again, first and foremost say, how do I make sure she knows she is safe? So, what do I need to do in my environment, in the counseling space, the education space, to make it welcoming, non-judgmental, and private, confidential, knowing that what she says is going to be kept right here? Her nervousness, her anxiety, her discomfort is acknowledged. We don't ignore it. We don't think, okay, well, she's nervous, but we're going to just power through. We say, I acknowledge your nervousness, your discomfort. This space exists to help you. And we're going to help you in whatever way that we can, step by step, without pressure. We have to establish that sense of safety first. She showed up. That can be celebrated. We could say, you came today. That's amazing. That's thank you for coming in today. Right? It's not about, again, being patronizing. It's about helping this person to know it takes a lot of energy to come into an environment you don't necessarily know whether you can trust or feel comfortable in. Thank you for being here. We want to validate her experiences, her emotions, express empathy for her situation. Also, let her know the purpose of why she's here. So here's what we can and cannot do. You're in control of the conversation. We're going to talk about what you came here to talk about, rather than, well, you're diabetic, so here's a list of low glycemic foods and here's a list of fruits and vegetables, right? No, we're going to talk about what you're here to talk about. What is it that you're hoping we're going to discuss today? What is it you're hoping this center is going to be able to offer you? Instead of focusing on what she, should eat, we're going to focus, engage with her in a strengths-based, right, empowerment conversation. What do you feel comfortable preparing? Or What are some of your favorite places that you go? What are foods that are comforting to you? What are foods that you feel really are important to her and her children? And what are small, realistic things that can be done? All right, you're going to eat through fast food. Where do you go? And let's talk about what can be some of the healthiest options you can get given the reality of your current situation working with fast food. I cannot say to her, look, fast food isn't good for you. It's not going to be good for your sugars when we aren't acknowledging the fact that that is what she has available. So we are going to put her in a safe space to say, we're going to work with what we can do. What are the collaborations out there? So is she aware of meal programs, community food resources? Is she aware of what SNAP benefits are, or food banks, or community congregate meal programs, or anything else that she may not realize is available? She may think that's for other people. I'd be too embarrassed to go there, or any other number of things that can come up. But we're going to collaborate and say we have tons of people, resources, support systems that are here solely to help you and your children feel better and to get the food that you need. And we're also going to recognize that whatever her food choices are, well, what is her background? What are these foods of cultural importance to her in her diet? And we're going to do so in a way that is open ended, again, allows her to be able to share her story, her history, her narrative. It's not to say that if Maria came in and we gave her patient handouts and said, you really should see an endocrinologist and you really should do this and you really should do that, that our efforts aren't coming from a place of a desire to help, but to do in that very direct kind of way that does not allow this person to share their story with me. That is what it is to not then act from that trauma informed perspective. We know that when healthcare professionals engage in these approaches, these 6 simple approaches we've talked about, they have better engagement, they have less re-traumatization, and they have more measurable mental and physical health outcomes. So it's not just a nice thing to be able to do, it is a measurably beneficial form of practice. So when we think about trauma and trauma-informed practice, it is to work from this both in terms of dealing with the realities of what is happening, but of course, as always, again, as public health-minded people, we want to try to prevent these kinds of traumatic experiences in the first place. So we can think of them from primary, secondary, and tertiary forms of prevention, and we can look at them from the individual level all the way to the societal level. So I won't bore you by reading through everything right here. You could see it before you, but just as a couple examples, lighting parking lots, lighting streets, preventing areas in the community where there can be dark areas that people can hide. That is a way that we can help prevent crime and the types of violence that people might experience in a community. So do we go to town hall meetings and say, this block, this block, this block, and this block have very little lighting in their parking lots or very little lightings on the side streets. What do we need to do to get lighting there? And here's the reason why it's important. And here's the research that talks about it. This is what trauma-informed practice is. It is to really look at our environment and say, what is conducive to health? And what are those things that might be very easily missed that can lead to ongoing trauma in different areas? When we think about children and we think about bullying programs in schools, I mean, it really is to talk about the fact that early intervention is key for kids. And when a lot of times people say, well, yeah, bullying happens, that's just the price of growing up. That is just a way of being neutral in the face of environments that cause trauma. So, for example, with food security in children, we might say, well, schools offer school lunch. Maybe they even have breakfast programs. Maybe they have after school food programs. This addresses any issues with food security in our community. That's great. But that assumes children feel safe at school. So if there are reports and we know that there are incidences of LGBT students not feeling safe at school because they regularly experience bullying by their peers, by their teachers, in addition to the fact that that bullying is going to be traumatic, they're not spending extra time at school to go to these lunch programs or breakfast programs or after school programs. They want to get away from school as quickly as possible. So are we talking about these things and saying every time that kid feels afraid here, even though this school may actually have really good resources for someone who might be food secure at risk, It's not of benefit if they don't feel safe in this environment. So these are the kinds of discussions and the kinds of preventative strategies that we want to continue to think about, talk about, and champion. It is not reinventing the real wheel, frankly. I mean, it's actually very direct, purposeful efforts. It is helping the people in our environments and our communities recognize how important these kinds of changes are. So when we think about next steps in trauma-informed practice and public health, it's bringing our skills, it's bringing what we are so good at in public health into our community conversations more. At the primary level, the effort here is preventing exposure to trauma itself. Of course, as best we can, what can we do to help someone not experience that trauma in the first place? For those that have, how can we get them as early as possible? So, from that secondary prevention, those efforts are prevention of trauma related sequelae. So, how can we get them into care? How do we screen for trauma as early on in life as possible so we can give people the ability to gain the support and the resources they need to not let it fester over time? And then, lastly, at those tertiary levels of prevention, how can we slow the progression of trauma-related illness and disability for people who have been living with chronic trauma for a while through better resources, educational campaigns, community health efforts that are culturally competent and culturally driven so people know that they belong and that they feel safe going. For resources, if you're interested in learning more about this, some of the best resources that are available for continuing education is Trauma Informed Care Implementation Resource Center. The Administration for Children and Families has excellent resource guide here on trauma-informed care, especially for those in the human services. And the National Child Traumatic Stress Network, again, has excellent resources on trauma-informed care, especially from the perspective of those adverse childhood experiences. So I want to end with this is just a couple key comments here about public health has significant advantage at being able to adopt those kinds of trauma-informed areas of care, maybe even more so than our colleagues in more of the inpatient or clinical side of care. Because through public health, we are able to address trauma through all of its different roots, through early intervention efforts and prevention networks, of course, but it's through policy, it's through education, it's through urban and community design, it's through it's getting access to food. It's getting people to feel that they have safe places they can go. How do we get people to know that they can access the healthcare system? It's not to say that it's easy, but that is where that collaboration comes in. When we collaborate, when we pull all the different stakeholders together that need to be part of these decisions, everybody is able to bring some of their resource, their expertise, and their knowledge in to lead to ongoing success. So trauma, unfortunately, is universal and it is common, much more common than any of us really probably fully realize. But we know that even minimal improvements in the community design and community outreach that has these kinds of more trauma-informed practices, there are successes and they really do lead to measurable positive impacts. But because we're talking about trauma, we need that long view of time. We won't see the real benefit of our work for another generation or two. So it's also connecting with and reminding the people that we work with this isn't the kind of thing where in 5 years we're going to say, we did it, we fixed it. Maybe in 25 years, we'll be able to look and say, look at what happened as a result of our work. So it's also helping to lead the discussion in this area to help people know that they need that long view of time and the patience needed to allow these trauma-informed aspects of public health practice to really set root and start to offset these historic and generational traumas that are still very present in our society today. So I am, again, incredibly grateful for you all taking some time to be here. I'm going to stop sharing my screen. And if anybody has any thoughts, questions, comments, please feel free to put those in the Q&A if you haven't done so already about anything that we've looked at today so far.
Yeah, well, great. Thank you so much for that. All right, so starting off, the first question I have is, how can public health agencies begin to shift organizational culture towards a trauma-informed model, especially in resource-limited settings?
Um, I think the way that we start to shift that is, again, kind of by saying like we need to reorient the way we evaluate success. Um, and I know that that's a hard, I don't know, that's a hard pitch to sell about that we have to be patient and wait, but I mean, that is really what it is to have a more organizational shift towards trauma-informed practices, to really take the time and say, whatever your or my organization does, the community we work with, the types of health outcomes we're trying to get, what needs to be done to look at this over the course of decades as opposed to months or even years, so that we are creating a culture that says we're looking at this in the long view of time. And I think the benefit to that, not only does that lead to better success, but it takes some of that immediate pressure off. If we don't show benefits in the first year, it must mean the program is a failure. It's shifting that discussion to say we want to think about these things in a much more, how do I want to say, we're thinking about these things in a way that recognizes the fact that it takes time to rebuild trust. It takes time to get all the voices in the room that need to be there and start to listen to one another and talk about it. So I think those are some of the ways that we can shift that culture around, is by just acknowledging the fact that we need to be willing to take our time and really say what needs to be done and how much time is needed to do it correctly.
Great. Okay, so we have a comment. It says, "Thank you, Anthony, so much for the cultural and ethical understanding,
Thank
and
you.
thanks for the recommendation to apply to their existing work." All right, so our next question is, how do you avoid a one-size-fits-all approach to trauma-informed practice?
That's a great question. I think to avoid that one size fits all is to, that's where that cultural competence, I think, and that humility comes in. It's to recognize that there's more to learn. There's more that we need to do to kind of, there's more knowledge we need to recognize the nuance. So, for example, even people who are part of a particular demographic group aren't, it's not a monolith, right? People who might be part of, let's say, um, the African diaspora. Well, is that from the Caribbean? Is that from mainland Africa? Is that from South Africa? Is that from Northern Africa? Just by saying we want to work on African American health, that can have a real one size fits all approach by kind of almost saying, well, everybody who's part of the African American culture is the same, which of course is not true. And so cultural competence and cultural humility allows us to recognize the fact that no, there is not only great diversity within this larger demographic group, but what is true of that culture today may not be true of what it was 20 years ago. And so just because I feel like I really understood this community when I started to work with them way back when, that may not be true today because culture changes and people's temperaments and their sensibilities change. And so getting stakeholders from the group itself, from the community, I think are necessary to avoid that one size fits all approach, because it allows the current, right now, lived experience of people to be heard, to say, well, this is what's happening, or this is the way we're seeing it, or this is what we need. So we're allowing ourselves to listen versus always going into expert mode, which might be driven from our desire to help, but it can be very helpful to just take a step back and listen a bit more.
Yeah, great. All right, I think this will be our last question. But this one is, can trauma-informed practice help to restore trust in communities that have been historically marginalized?
I mean, in a word, yes, that's the goal here, is that trauma-informed practice, what am I trying to, remedies the fact that even those groups, those organizations that have attempted to help in the past are often complicit in trauma because they are going about it from what they think is correct, they think is right. This is what you need, whether you like it or not. It's kind of that real paternalistic approach to healthcare, where the whole goal of trauma-informed practice in this way is to almost to say, for lack of a gentler way of saying it, like, I'm going to shut up and you're going to talk. And I'm going to create an environment in a community, in a space where you can talk. And all I'm going to do is listen. And I'm not going to explain. I'm not going to justify. I'm not going to go into defense mode. Um, I, you know, I think a good example of this right now, which again is nothing new, but we continue to live in a community and an environment where there's a lot of vaccine hesitancy. And I think part of the reason this remains is because people in healthcare aren't always good about acknowledging the fact that there are many people who are so genuinely afraid of what this means because of past issues of people having medical care given to them against their will or having their medical autonomy taken away. And once again, it's, oh, trust us this time. This time we're doing it for your benefit, we promise. And too often we are too quick to say, no, just trust me, just trust me, just trust me, as opposed to, I want to hear all of the reasons why you are afraid to receive this care or to receive this vaccine or to distrust medicine so I can better understand the reason for your hesitancy, and not try to, educate you into agreeing with me, but rather let's see what the real core issue is why you don't trust my local health department when it's saying, no, please get a flu vaccine this year, or whatever it is that it might be. So we can have the opportunity to have those larger discussions without the goal of convincing anybody of anything, rather just letting people share their stories. And I think that will go a much further way of helping to restore trust by people saying, they let us talk, they let us share, and they didn't make me feel dumb or uneducated or stupid or something like that because I have concerns or fears in this particular area.
Great. All right, we had one last question
Okay,
come
perfect.
up. We'll let this one, this one will be the last one.
Okay.
This one, they say, can you share how you think AI is affecting or will affect trauma care?
That's a great question. And I personally am of the belief that AI has the potential to be a really excellent tool for public health and healthcare delivery. But the reminder that I am constantly giving myself, but other people too, is AI is only as smart as what has been programmed into it. AI doesn't, at this current stage necessarily, um, it doesn't think, for lack of a better word. Maybe we'll get to the point that it does, but right now it's like Google, where the stuff that it puts up isn't because the top response on the search is the correct one. It's just the most popular one, or that's what the algorithm spits out. And the same thing is true with AI. We want to be very thoughtful with AI right now because AI just knows what it's been told to do, which is, well, this is how to talk, or this is how to synthesize information. And AI then is therefore susceptible to whatever biases or unconscious issues or whatever of who programmed it. So if the person putting in that data, that information, feeding the AI system is itself operating from some unconscious biases or things like that, that will be present in the AI too. So I think AI will eventually be a good source, and I think it can be a really good source in public health practice and care. But um, as of right now, we don't want to I wouldn't put too much blind faith in it just yet, because we still want to be critical when we're evaluating what comes out of it. But that being said, I think AI does have the ability right now to synthesize a lot of information in a kind of an easy to understand way. So if I'm trying to create educational materials or trainings or things like that, that is where AI, we can feed it a bunch of information and it can synthesize it maybe in a more user-friendly way. So it has the potential, I think, to get there. But we're probably still a bit far off for where this will be a really error-free or a more error-free way of practicing, if that makes any sense.
Yeah, it does. Definitely. All right. Well, that was our last question this time for sure. And I just want to say we're getting lots of comments saying thank you so much for this presentation. People really seem like they've appreciated it.
Thank
And
you,
I want to
everyone.
thank all of you for being here today too. So we do have our next webinar Wednesday next month on the second Wednesday. So I hope to see everyone else again there. And one final thank you, Anthony, for being here today. And I hope everyone has a great rest of their week. Thanks.
Thank you so much. Be well, everyone.